Good afternoon and good evening, ladies and gentlemen. I am Dr. Rahul Manlik. Welcome you all on behalf of Shalina Healthcare to this online panel discussion. As a healthcare professional, you must be encountering many common health diseases or health issues. Uh, Something like patients rushing to you in panic and complaining about the chest pain, or someone is suffering from the chronic coughing or asthma, and sometimes patient coming with the complaint of laryngitis. If we see at these conditions in isolation, they appear to be associated with the different pathologies, but there might be a common thread which link them together, and this can be gastroesophageal disease, that is popularly known as GERD. Today, our eminent panel members are going to discuss about the enhanced approach to GERD, mainly focusing on the primary care practice. Briefly about us, today Shalina Healthcare is one of the leading pharmaceutical company in Sub-Saharan Africa, and from last 40 years, we are working towards delivering the quality and affordable medicines to African patients. And we achieve this by providing end-to-end services and by manufacturing our products in our WHO approved facility. We are also working with several institutions, NGOs, as well as professional bodies to deliver best patient care. This webinar is brought to you by Shalina Academy, that is initiative from Shalina Healthcare, and we already have completed Silver Jubilee of these Africa webinars under Shalina Academy, and this is 26th program in this series. With this, let me initiate by introducing our panel members to you. Let me start with Professor Godash Chaudhary. Sir is the chairman at Department of Gastroenterology and Hepatobiliary Sciences at Fortis Memorial Research Institute, Gurgaon, India. He is Honorable Professor at Vivekananda Institute of Medical Sciences, Lucknow, India, and he is a former professor and head of Department of Gastroenterology at Sanjay Gandhi PG Institute of Medical Sciences at Lucknow. Sir is a former president of Indian Society of Gastroenterology, and he has served as a council member of many international reputed bodies, and one of them is World Gastroenterology Organization, that is WGO. And Sir is also fellow of World Health Organization for Health Promotion, and he has published more than 200 scientific articles in reputed medical journals. Welcome to you, sir.
Pleasure to be here.
Moving on to our next panelist, Dr. Felix. Sir is a member of West African College of Physicians, and he is a head of internal medicine unit at Holy Family Hospital, Techiman, Ghana. He is also a senior resident in gastroenterology and hepatology at Korlebu Teaching Hospital, Accra, Ghana, and he is a part-time lecturer at Anglican University College in Ghana. Welcome, Dr. Felix. Now, moving on to our moderator, Dr. Priscilla. Madam is a senior specialist family physician and head of department at Korlebu Polyclinic Family Medicine Department at Korlebu Teaching Hospital, Ghana. And she is a fellow of Ghana College of Physicians as well as a member of the West African College of Physicians. Dr. Priscilla is a co-founder of Global Outreach Consortium, an NGO that facilitates health services to underprivileged patients. So, dear audience, today's program has three sections. So, first section is panel discussion. Section 2 is Q&A session where we will take up the question posted by you. So, please feel free to post your questions and feedback in the right side box provided to you. And the last section is about the launch, which is very specific to our Ghana healthcare professionals. So I would also like to inform you that you can instantly get your certificate of participation signed by our respected panel members. And to get this at the end of panel discussion, please click on the quiz tab provided on the live web page. take a short quiz, and you can download your certificate. Now, let me hand over the session to our moderator, Dr. Priscilla. Over to you, ma'am.
Thank you very much, Dr. Rahul, and welcome everybody to this afternoon or this evening's CPD. I'm sure you are all ready to learn about GERD, which is a very common condition which you will appreciate as the discussion goes on. So I will start by sharing briefly what the burden of GERD is and why it's a topic that we need to discuss. So Dr. Rahul, if you can share my slides. Okay, so the objective of my brief presentation is for you to appreciate the importance of GERD as a disease of public health importance. Next slide. So worldwide, there's a very wide disparity in terms of determining the prevalence of GERD. So if you take the European region, for instance, some studies put the prevalence of GERD to as low as 8.8% and as high as about 26%. And if you come down to Africa, it's reported that we have about 61% of sufferers of GERD worldwide in sub-Saharan Africa. And interestingly, when you go to Asia, in East Asia, there's reports of prevalence to be as low as 5.2% and as high as 38.8% in Southeast Asia. So this tells you there's very wide disparity in terms of exactly who is suffering from GERD. And as we go along, you may better appreciate why there appears to be this confusion. Next slide. So let's take a study in the USA, where 1 out of 5 people were reported to complain of heartburn or acid regurgitation on a weekly basis. And in that same study, 2 out of 5 people were also said to report of heartburn or acid regurgitation on a monthly basis. And the American Gastroenterological Association did a study which concluded that about a third of all the population in the US suffer from GERD. And interestingly, about 54% of this study reported that this was in African Americans. Next slide. So why is GERD important? So several studies have found that it has cost implications. It is a chronic disease and it has an economic impact due to the long-term management of the disease and the very wide range of symptoms which contributes to the expense of medical visits. And some of them point to respiratory conditions, others point to gastroenterological conditions, and others also point to cardiac conditions. And these wide range of symptoms means once you are investigating, it will increase the cost to the patients. So the direct costs include over-the-counter medications and prescription medications that the patients might buy, visits to the physician office, and sometimes even admissions, diagnostic tests that you want to either rule in or rule out, and also their treatments as well. And a study conducted in the United States reports that the direct cost of GERD in a year is about $9.3 billion when you consider the holistic healthcare cost. The cost implications also has some indirect cost as well. So, for instance, a patient suffers from GERD and the person will be missing work. The person reports to work, but because of the symptoms, there's decreased productivity. And there's also impaired activities of daily living because of the symptoms of GERD. Another study in the United States also reported that both the direct and indirect costs totaled the healthcare cost of about $10 billion in a year. Other studies worldwide reports that in the United Kingdom, about 760 million pounds per year is incurred in trying to manage the direct and indirect implications or the outcomes of GERD, and $24 billion in the United States. Next slide. So let's come to the sub-Saharan African continent. As I mentioned earlier, there appears to be some kind of wide disparity in terms of the exact prevalence, and that is because of the wide range of the symptoms. But a recent meta-analysis reported the prevalence to be between 15 and 20% in the West African region. And a study done in Nigeria, where about 3,500 subjects were recruited and about 7.6% of them satisfying the diagnostic criteria for GERD, they realized that within that population that satisfied the criteria, about 30% of them were actually suffering from GERD. And interestingly, those who were suffering the most were undergraduate students. And so you can imagine how that can affect their studies. Next slide. We look at Zambia. A research project reported about 34% of people suffering from heartburn, and a systemic analysis that was done also puts the prevalence at 9.9%. So in Zambia alone, you see the prevalence is between 10 and 34%, and it's also reinforcing the fact that there appears to be some confusion about how to address it. Kenya, a study was done and it was about 10%. Next slide. So a study was done in Ghana where about 2,400 patients that had undergone upper GI endoscopy for various reasons. And most of them, their primary complaint was epigastric pain. And in evaluating the findings, they came to the conclusion that 17.3% of them suffered from GERD. Next slide. So I would just like to conclude, and I hope I've whipped your interest, that what kind of disease is causing so much discomfort in people's life, and what kind of disease is costing so much in the healthcare sector, and what kind of disease is causing such a wide disparity in determination of its prevalence. And I think it's important that we learn a lot about GERD because it affects the quality of life of our patients. So now we'll be going to the panel discussion. So I'm presenting to you, next slide, yes. I'm presenting to you Peter, a 40-year-old bank professional. He enjoys playing tennis about 3 times a week. He consults his primary care physician because for the past year, he has had a persistent cough. It wakes him up at night several times a week. And sometimes the cough is accompanied by regurgitation, which is often associated with a non-radiating retrosternal pain. Occasionally, he will drink water to help settle the cough, but it really doesn't relieve him. And he worries that this chest discomfort could be a sign of heart disease because of his stress at work. We will now start the panel discussion, and I want to find out from Dr. Godas, what really is the global consensus definition for GERD?
We have been, I'm very happy to be here in the panel. Thank you, Dr. Priscilla. This term acronym called GERD, it's very interesting. The first 3 letters stand for gastroesophageal reflux. And the D part is a little hanging in the air because it could mean disease or it could mean disorder. Both of them stand with D. But let me explain to you why I'm telling it. Gastrointestinal reflux disorder or disease basically is a term given to a condition arising out of gastric contents going up from the stomach into the food pipe and above. Okay. So if I can have the first slide, the Montreal definition, this was way back 2006, but essentially not much has changed. So the condition that develops when reflux of stomach contents occur to the esophagus, and it can cause either troublesome symptoms and or complications. Now, it's a little important to understand this. So, there can be some people, they can have only symptoms. You may not actually do an endoscopy to find whether there are complications. And if you do, you may not find complications also in quite a few, whereas some of them may have relatively minor symptoms, but on endoscopy based study, as Dr. Priscilla referred to, you can actually find evidence that they must have been having reflux. So both of them fit into the total definition of GERD, either symptom based or endoscopy based. And why I'm mentioning it, because when you see the wide variation in epidemiological data, it also depends on how the studies have been done. So if it is just a questionnaire based study, you will get one type of results. If it is endoscopy based study, you might well get a different type of results. But this is the crux of the whole idea of what is GERD. And if I may have my second slide. No, I think I had a second slide. Yeah. So, when we talk about GERD, it has got two perspectives. It has got the patient's perspective, which is very important when we are, in a platform like this where we are having a discussion with primary care physicians. So the patient's perspective is extremely important. It is symptoms and quality of life, and that is what is described. And how people talk about all the symptoms: heartburn, water brush, choking. What this case that Dr. Priscilla presented, many of the symptoms were there, and their severity depends on how troubled they are. So they may say, oh, it's very severe. On the other hand, the endoscopist, when he puts down a scope down the throat, he only looks at whether there are ulcers, whether there's a hiatus hernia, whether there's a Barrett's esophagus, and whether there has been, any of the changes which are due to the evidence of acid refluxing. So both the two perspectives have to be looked at when you look at a large, all-encompassing definition of GERD. Thank you.
Thank you
Over to
very,
you.
thank you very much, Dr. Kuta. So, Dr. Felix, can you tell us if there are any risk factors for the development of GERD?
All right, thank you very much, Dr. Van Dyke Say, and I'm also very glad to be part of this all important discussion. So, talking about the risk factors of GERD. Now, this slide is only to show that the risk factors can go as far as from the time of birth. And if you look closely at these slides, you realize that even congenital causes can be entertained. And you can have prematurity in itself with all the, the conditions that follow to be a risk factor for the development of GERD. This is not for you to cram, but this is just to make the point that it can start as early as in childhood. Now, if I could get the next slide, I would want to use a diagram to try to explain all the risk factors that can happen as far as GERD is concerned. So, I'm sure we are all familiar with this anatomy. We have the esophagus as a tube, and then there's this valve, which we are going to call the lower esophageal sphincter, and this would open and allow food from the esophagus to enter into the stomach. And then after a while, the pyloric sphincter opens and the food continues into the duodenum. Now, simple as this sounds, you can have several things that can go wrong with this very simple mechanism. We can caption the risk factors as far as this diagram is concerned into 3 or 4 different categories. So we have abnormal esophageal clearance. So when food is chewed, it goes through the esophagus and the food continues into the stomach. Now, as Prof earlier elucidated, food can once in a while exit the stomach up into the esophagus for every normal person. But when this becomes too frequent or when this comes with symptoms, then it becomes a disease condition. Now, the esophagus has a way of controlling this. When food gets into the esophagus, through peristaltic movements, the food is cleared from the esophagus as quickly as possible, almost seconds after the food is being swallowed. Now, this is known as the mechanical clearance. There's also a chemical clearance, which usually happens when saliva is swallowed. Now, saliva contains a lot of bicarbonate. So once you swallow saliva, it neutralizes the little acid that must have been left behind in the esophagus. What it means is that anything that is going to slow down the movement of food from the esophagus into the stomach can actually be a risk factor for the development of GERD. Now, the esophagus itself has some mucosal resistance which prevents injury to the esophageal mucosa. There is the pre-epithelial, the epithelial, and then the post-epithelial. But basically what happens is that the squamous cell of the esophagus is structured such that it is able to withstand the little acid that gets into the esophagus, that is from the stomach. For some people, either due to genetic factors or some other factors, this mechanism is defective. And this is actually postulated to be the reason why some people with very bad symptoms would have apparently normal endoscopic finding. Now, still moving down the stomach, you can also have delayed gastric emptying, which could be from stenosis at the pylorus, and this would keep the acid in the stomach for longer than normal time, and then some of the acid can escape up into the esophagus. There are also some metabolic conditions like diabetes, which can cause gastroparesis and generally decrease the time the food exits the stomach. Now, let us take a closer look at the lower esophageal sphincter. This is formed by the legs or the crura of the diaphragm. And this can go wrong if, for any reason, the sphincter mechanism is pulled into the thoracic cavity. This reduces the pressure of the lower esophageal sphincter and might allow food in the stomach to exit. There's also this concept of the angle of His. Now, there's an angle which is assumed looking at the entry of the esophagus into the stomach. Now, if you draw an imaginary line at the fundus, and then you draw another imaginary line at the point of the esophagus entering the stomach, there's an angle which you would get, and this is the angle of His. Now, the more acute this angle is, the more food is prevented from moving up the esophagus. And that is why some conditions can alter the angle and then cause GERD. So if I could get the next slide, you would realize that most of the risk factors can be tied to this pathophysiology. Next slide, please. So things like obesity. So obesity can relax the lower esophageal sphincter, and then it can also increase the pressure in the stomach and cause food to move up into the esophagus. So will be hiatal hernia. Pregnancy would increase the pressure in the abdomen. Also, the progesterone effect can reduce or relax the tone of the lower esophageal sphincter. And things like delayed stomach emptying, which I've described, like diabetes, or if you have an ulcer around the pylorus, which causes edema, or you have scar formation around the pylorus, you would have the acid staying in the stomach for longer periods. Some meals are also known to be a risk factor for GERD. So meals that will decrease gastric emptying, and usually fatty foods are known to decrease the gastric emptying time, and also some beverages like alcohol and coffee, and medications. Now, in terms of medications, there are several of them. Next slide, please. And this slide is supposed to look at the very common ones that can be a risk factor for GERD. NSAIDs would be one very common class of drugs that can increase your risk of getting GERD. And so are drugs that causes relaxation of smooth muscle, so the nitrates. And then you'd also have albuterol. And as I said, this is not an exhaustive list. Thank you very much.
Thank you very much, Dr. Felix. Sometimes we have people describing heartburn, regurgitation, as well as dyspepsia. Are they all the same thing, or are there differences between these terms that patients and clinicians tend to use?
Thank you very much, Doug. So indeed, these terms are used loosely interchangeably, but technically speaking, heartburn is actually a symptom of GERD, and so is regurgitation. I'm not sure why the word heartburn is still being entertained because, as you would notice, pain in the chest can be of cardiac origin and also can be of non-cardiac origin. So I would have expected that the word heart wouldn't show up at all in a non-cardiac cause of chest pain, but that is just what it is. So the word heartburn and regurgitation is actually what happens when food from the stomach is exiting into the esophagus. Now, because most of the acidic content of the stomach is causes pain when it gets up the esophagus, realize that the patients will complain of a burning chest pain, which most people would describe as heartburn. Now, dyspepsia, on the other hand, is actually a broad term for a range of symptoms. So, abdominal bloating after meals, early satiety, and pain or burning sensation in the upper GI. Now, when this dyspeptic symptom can be linked to a particular organic cause, then the term dyspepsia is used. If no obvious organic cause can be ascribed to these symptoms, then the term functional dyspepsia is used. So basically, just to conclude again, heartburn and regurgitation can all be symptoms that describe dyspepsia and GERD. Thank you.
All right, thank you very much. So, Dr. Godas, usually what causes the most expense to patients who have GERD is the exclusion of cardiac conditions. So, how do we go about distinguishing between non-cardiac chest pain and cardiac pain?
Okay. Before I just go to that question, I'll spend half a minute. So, in addition to what Dr. Felix said, and I fully agree with him, there is a esophageal part of it that is called heartburn when the esophagus is the source of pain. And he very rightly called it burning because, cardiac chest pain usually tends to be pressure or crushing. But nevertheless, sometimes it's very difficult to distinguish. So that is when the symptoms get confined to the food pipe itself. And the food pipe lies very close to the heart. So some people complain of chest pain, and in a person whom Dr. Priscilla just described, 40-year-old, I don't know about his background, whether he's obese or not, if he has hypertension, if he has a family history. But if it was a person, say a diabetic, hypertensive, 50-year-old obese smoker, sometimes it's very difficult to distinguish between a cardiac source of pain and an esophageal source of pain due to reflux. So there are many causes of non-cardiac chest pain, but one of them is actually reflux. But there are other causes also arising from the esophagus. So how do we distinguish? The common things that I would do as a physician, which I normally do, is try to find out what is the timing, what are the precipitating events, and what are the other associated factors. So if it occurs while a person is walking, and if it's a heaviness and he stops and he gets better, I would think more in terms of cardiac if the person has a predisposition. If on the other hand, if it's a burning sensation which occurs or a choking sensation, as in this person, it occurs and he gets up, takes a few sips of water and he settles it, it could well be reflux. So this is broadly the way to look at it. If it's associated with sweating and breathlessness, more likely to be cardiac. If it settles down with a gulp of antacid or water, it's probably likely to be reflux. If it settles down with a course of a proton pump inhibitor or one of the antacids or alginates immediately, that's within a few minutes, more likely to be reflux, especially if it has occurred after a heavy meal, a late dinner with a lot of fat and chocolates and wine. And of course, if it is the other way around, if it's more likely to be cardiac. So this is broadly the issue. But the definition of non-cardiac chest pain implies that when you are in doubt, you must rule out the cardiac part first, because the cardiac part is more important from the point of view of life. So the symptoms of GERD can be distressing, but usually they don't kill. Whereas the cardiac pain can result in a myocardial infarction and can actually be fatal. So that's why many of them would actually come to the emergency at night. They would often require an evaluation, a cardiac evaluation, like a ECG and a tropi test. And then, if suppose everything else is okay and they get a shot of proton pump inhibitors or antacids and they settle down, then they are sent home and then they are called the next day. Otherwise, they are kept for observation. So these are the two broad categories that Dr. Priscilla wanted me to say. In my earlier question, I think I missed out one thing. There was this question about extra esophageal symptoms. So regurgitation means that the food contents are not just confined to the esophagus, but they come to the mouth and to the throat. So water brush is a very important symptom. That's the mouth gets filled with sour fluid containing acid or food. Sometimes you tend to choke and it goes to the other side, the windpipe. So one gets up at night with a choking sensation. Sometimes the nocturnal asthma can be a presentation. I think Dr. Rahul mentioned chronic laryngitis. Yeah, some people have a sore throat and it goes on, and the cause is nocturnal reflux. And I get many referrals from dentists who actually see the teeth getting eroded because of acid. And they tell the patient, go and meet a gastroenterologist because looks like acid is coming up. So these are some of the other things that I think as a physician, it's good to be aware of. Thank
All
you.
right. Thank you very much, Dr. Godas. So, having said that, do you think we can comfortably make a diagnosis of GERD without additional diagnostic tests in the primary care setting?
Oh, me, I think absolutely. The primary symptom of GERD are its symptoms, and especially if it is heartburn, water brush. These are two easy things. If it is nocturnal choking, they are fairly typical. And I think that, in a person who does not have alarm symptoms, or if he is not really having crushing type of chest pain, a person who is predisposed, it is well worth first presuming that it is GERD and giving him a treatment and seeing the response. Even the Western world has accepted that there is a kind of a test which they call it a therapeutic test. It's called a proton pump inhibitor test, PPI test. So if you give this person a double dose of something that knocks out the acid and you give it for 2 weeks, you get a 90% response. It speaks very much in favor of reflux being the main cause. But yes, if there are any doubts, I think it's always good in a person, as I told you, 50, 55, 60-year-old obese, hypertensive, and you are in doubt, it's always good to get a cardiac evaluation done. The positive diagnosis of GERD, endoscopy is done for many other reasons, but primarily, unless there are alarm symptoms in a young person, it may not always be necessary to put a person through endoscopy.
All right. Thank you very much. So, Dr. Felix, do we have any diagnostic tools that will help us to more or less clinch a diagnosis of GERD?
Well, thank you very much. And as Prof said in his earlier submission, there are actually a number of diagnostic tools that can be used in the diagnosis of GERD. And if I could get my next slide, please. So there are a dozen of them, but the very commonly used ones are the GERD-KIO questionnaire, the RD-KIO questionnaire, which is the reflux disease questionnaire. There's also the FSSG, which is frequency scale for symptoms of GERD questionnaire, and then the gastrointestinal short form questionnaire. But of these, the commonly used one is the GERD-KIO. And if you could just give me a little bit of your time so that we go through the GERD-KIO questionnaire. So it just answers 6 very simple questions, and this will be administered to the patient, and the patient would have to take, depending on the number of days he or she has been having these symptoms. So you would ask the patient whether he or she has experienced these symptoms in the past 7 days, and in a week, how many times he or she would have these symptoms. So one will be, how often did you have burning feeling behind your breastbone or your sternum? So if it is never had this symptom, he or she would take 0. And then if this symptom happens at least once in a week, as in one day in a week, then the 1 column will be ticked. If this happens between 2 to 3 days, the 2 column will be ticked. And then if this happens between 4 to 7 days, the 3 column will be ticked. And this will be continued to the very last question. And at the end, the total score will be computed. So for most research papers, anything greater than 8 points is considered significant for the diagnosis of GERD. And this is something you can administer, in the primary healthcare setting without any further investigations. But I must be quick to add that for you to use this diagnostic tool, you should have ruled out, pain of cardiac origin, as Prof said earlier on, and you would have to rule out any alarm symptom. Because once you have alarm symptoms as part of this whole condition, you would want to go further to do other additional investigations. Thank you.
All right. So you mentioned alarm symptoms. Can you tell us a bit more about the alarm signs and symptoms associated with GERD?
So in terms of alarm symptoms, if I could see my next slide, there are just about a few. So if the patient with GERD comes with difficulty in swallowing, especially when it comes with weight loss or some jaundice or a palpable mass, in any of the head and neck region or in the upper chest or upper abdomen, you would want to pay a little bit more attention to it. Now, some would also have chronic atypical chest pain. Again, if you have a patient who has a family history of a GI malignancy, usually a first degree relative, then you would want to pay a little bit more attention to such a patient. When you also have a patient who is having these symptoms, 60 years or older, you would also want to, pay a little bit more attention to this patient. So these are the alarm symptoms that you would have to look out for. Thank you.
All right. Thank you very much. So, Dr. Godas,
Yes.
at what point in time do you think in the primary care setting we have to refer a patient to the gastroenterologist?
I think if a person has been having symptoms for a longish period of time, and it started young and he's in his 40s, responds very well to acid suppressants, I'm not worried, but usually the patient is worried. So in that situation, it might at sometimes be worthwhile getting him over to a specialist in order to reinforce the fact that, yeah, it was what we thought it was, that it is GERD. More important is that if there are any alarm symptoms, which Dr. Felix talked about, I think it's always good to get it done through a specialist, either a gastroenterologist first and a cardiologist subsequently, so that we don't miss out any other disorders. The third, Dr. Felix touched that very important point. If it is symptoms which are occurring for the first time in a person who's, say, around 55, 60 or above, then it's unlikely to be a simple GERD, because most GERD symptoms usually start early. So if it is occurring a little late, as we grow older, the chances of malignancy go up. So I think it would be much better to go and get an endoscopy done so that we are not overlooking anything. All the alarm symptoms which Dr. Felix mentioned, I fully agree with that. A person could have bleeding, which is visible bleeding, or he must just have a hemoglobin which is low, which indicates occult bleeding. So any of them would require. or a person with unexplained weight loss. So I think all these patients need to be sent. And of course, for cardiology reference, if there are any doubts regarding the nature of the pain or discomfort, and I might tell you, we usually think in binary terms that it's either GERD or cardiac. No, actually, quite a few patients can have both. And you know why? Because people with cardiac disease and hypertension can be on many of these antihypertensives, which relax the lower esophageal sphincter. They are often taking aspirin, which worsens reflux, and they actually have well-known cardiac disease. So both can coexist. So if there is any doubt, the more importance should be given to the cardiology part. If he doesn't have a heart attack and die.
All right, thank you. So, Dr. Felix, can you touch briefly on some of the complications of GERD?
Thank you very much. So as Prof indicated earlier, GERD would usually not kill the patient, but it will come with a number of complications that can be detrimental to the patient's health. So by and large, we would want to look at this diagram, which gives us the esophageal and the non-esophageal or extra-esophageal symptoms, or complications, I mean. Now, for the extraesophageal complications, you have stimulation of the airway, which can give you asthma-like symptoms. So, in fact, GERD can be looked at as an asthma mimic, and it can also be looked at as a condition which makes asthma worse. So, for our colleagues in the respiratory fraternity, they can actually start thinking of GERD if you have a patient with asthma which is not responding very well to the traditional medications we use for asthma. In fact, the medications for asthma can in itself trigger GERD because these are smooth muscle relaxants, and the LES, or the lower esophageal sphincter, is also a smooth muscle. So for the esophageal complications, if I could have the next slide, you can have inflammation, which is the esophagitis. You can also have strictures. And then if this inflammation goes on for a long time, you have a condition referred to as Barrett's esophagus. This is when the normal squamous epithelium of the esophagus is replaced by columnar cells just to be able to accommodate the recurrent acid reflux. And this is considered a pre-malignant lesion. So it can also sometimes lead to esophageal cancer. For the extra esophageal complications, you can have a feeling of a mass in the throat, and this is quite a common presentation. And you go look into the throat but find nothing. Some can have hoarseness of voice, inflammation of the larynx, and there is a very small postulated possibility that patients with GERD can actually have laryngeal cancer. The studies are not too straightforward, but there's that possibility. And I've spoken about the fact that the pulmonary complications can either mimic asthma or can also make asthma worse. Thank you.
All right, so I'm sure you learned so much so far. We are halfway through the panel discussion, and remember to post your questions in the box provided. So we want to look at how do we manage GERD now, and we are going to look at the non-pharmacological management of GERD first. So Dr. Godas, how would you advise that we manage GERD non-pharmacologically?
Okay. So there are few general issues and there are some few specific issues. So I'll tell you what are the important points in history that I take. Is it a GERD, are the symptoms there in the daytime or is it primarily in the nighttime? There is a condition called nocturnal GERD, and that is actually pretty common. Nocturnal GERD usually occurs because, during the daytime, we are vertical. So because of gravity, the acid tends to remain down in the stomach. But when we lie down and become horizontal, then the effect of gravity goes away. And therefore, if there is a loose lower esophageal valve, acid tends to go up into the esophagus and into the mouth. So the strategies would be somewhat different in the two. That's why I usually take that history. Number two, the common general things are that if the person is overweight, he should bring down his weight. That's one of the typical predisposing factors. I think if he's on certain medications which worsen reflux, we should try and see if we can modify or change them. Number three is in his lifestyle. The patient whom you mentioned, Dr. Priscilla, he plays tennis 3 times a week. I was very happy to hear that because in India, most people are very lazy and they don't play. So if they don't play and they put on weight, it's very important to give them that little instruction on lifestyle as to walking, getting their weight in order, and so on and so forth. But coming to the last part is the dinner. You see, for people with nocturnal reflux, the commonest culprit is the food they eat at dinner. So if it's a late dinner, if it has a lot of fat in it, if they're enjoying their dinner too often with a lot of alcohol, they are disastrous. And I advise them to take very early meals, avoid fat for dinner, make it something very simple like rice or oats or something like that. In fact, many people now are into intermittent fasting where they often skip the dinner and they're pretty well off doing that. So those things really matter. They have to keep the head end of the bed a little elevated so that the gravity keeps the acid further down. So these steps really help quite a bit in terms of overall lifestyle issues. With regard to the food, I'll just talk a little bit. Indian food is a bit spicy and fried, and that worsens reflux. I have seen that. I don't know about the food in Ghana if that's the way it is, but if people eat a lot of cheese and wine, and in Europe, for example, I think wine and cheese are very typical culprits, and in India we have fried things and chocolates. So if somebody is very fond of a bite of chocolate before dinner, oh, he will have a lot of reflux. So these are the simple things. The other two things are, of course, smoking. I think Dr. Felix mentioned that tobacco, that is nicotine, makes the lower esophageal valve somewhat loose. And also, nicotine is a very strong stimulant of hydrochloric acid. So, smokers usually tend to have a lot of problem if they give up smoking, and provided after giving up smoking they don't gain weight. A lot of people give up smoking and gain weight. Okay, so if that part they're careful with, then they can have a fairly good resolution of the reflux symptoms without resorting to much of pharmacology.
Yeah, thank you very much. So, Dr. Felix, usually when we have proton pump inhibitors like omeprazole, most people think it's used for the treatment of peptic ulcer. Is there a role of PPIs in the management of GERD?
Yes, indeed, there's a role for PPI in the treatment of GERD, and PPIs are indicated when patients do not respond to, the usual antacid-alginate combinations, or when they don't respond to the H2 receptor antagonist. Also, PPIs are indicated when patients have Los Angeles, usually B and C. They would have to be on it for the rest of their lives, really. And you can also give PPIs to patients who are having GERD symptoms that impair their quality of life. It should be, however, noted that PPIs should be taken at least 30 minutes to 60 minutes before the first meal. And this is because, the PPIs will block the, hydrogen potassium ATPase. And it is known that during the fasting period, you have a lot of the hydrogen potassium ATPase present on the parietal cells. So if you take it before meals, then you're able to block a lot more of, this enzyme. Now, it is also worth noting that there's no major differences in efficacy amongst the different PPI. So rabiprazole, esomeprazole, omeprazole itself, they are all generally equipotent. And usually what you do is to do a trial of, an 8-week course and then reassess this patient's to see if the symptoms are getting better. The major limitation to PPI is the fact that it is slightly more expensive compared, with the other treatment modalities available, and there are some few side effects that come with PPI. Otherwise, yes, PPIs are indicated in the management of GERD. Thank you.
Thank you, Dr. Felix. So, Dr. Godas, what about prokinetic agents like domperidone? Do they have a role to play in the management of GERD?
Yes, actually, I mean, as of now, the primary role seems to be for pharmacological therapy. The world over, it seems to be the hot favorite seems to be medicines which reduce acid production. So it's primarily PPIs, because PPIs are more effective in suppressing acid, but it could well be H2RS. Earlier on, it used to be antacids which neutralized hydrochloric acid rather than actually reduce production, but that was the usual line. People have now found that prokinetics can also be very beneficial. What prokinetics do is that they encourage the esophageal peristalsis, improve the clearing of the esophagus of acid, they increase the tone of the lower esophageal valve, the lower esophageal sphincter. And I think Dr. Felix mentioned a very important point of gastroparesis. Especially a lot of diabetics and people who take a lot of fat and chocolates and alcohol, their stomach doesn't empty well. So if the stomach is distended and food and acid remaining there, there is a greater tendency for it to go up. So if you take a prokinetic which clears the stomach and improves the peristaltic peristalsis, pushes the food down, then people get a lot of relief. The prokinetics which are normally used are, it used to be metoclopramide once upon a time, the first one. Now the hot favorite all over the world is one called domperidone. Domperidone is popular because I think the adverse effects are somewhat low. It's more easily acceptable, so it's very widely used in many parts, including in our country. And then you have quite a few of the other so-called prides. So you have etopride, mosapride, levosulpride. So quite a few of the prides, and we have quite a few of them in India. Many of them are not approved by the FDA, so they may not be there in other countries. But yes, these prokinetics do help. The overall strategy is to combine a prokinetic with a mild acid suppressant or an antacid, rather than to use a prokinetic just by oneself for a long-term reflux disease. Over to you, Dr.
Thank you
Priscilla.
very much. Okay, thank you very much, Dr. Goodness, for that. And Dr. Felix, usually we talk about antacids, and it's used for so many GI issues. Has it got a place in the management of GERD?
Yes, indeed. Antacids have a place in the management of gastroesophageal reflux disease, and it is usually indicated in mild and intermittent, patients. Patients who have intermittent symptoms. And it is also good for on-demand relief of mild GERD that occurs, anything less than once in a week. Now, it is worth noting that PPIs will not neutralize the acid already produced. What it means is that if patients start having symptoms, your best bet would be to do an antacid, because the PPIs, even though are very effective, and I always say PPIs almost rendered the surgeons jobless when it comes to management of ulcer, because it did so well. No patient needed vagotomy again, like happened in the past. But the PPIs will not be able to neutralize acid already produced. It can only stop the acid yet to be produced. So for patients who demand pain relief from mild GERD, antacids would come in very handy. And antacids are generally a combination of some, salts of magnesium or aluminium, sometimes calcium carbonate, and this would neutralize the gastric pH, and thereby decreasing the amount of acid that exits the stomach up into the esophagus. Now, the onset of action for antacids is anything between 5 minutes. That is, if you don't have any meal in there. But when you have, some meal, it could take a longer period. The downside is that it doesn't, do this for a very long period. So you are looking at a duration, anything between 30 minutes to 1 hour. Next slide, please. So generally, antacids would neutralize the acid in the stomach. It will alleviate the pain, as I said earlier on. It avoids corrosion because it neutralizes the acid immediately, causing the erosion or corrosion of the mucosa. And it is known that when the pain is on, when the GERD pain is on, there's actually a reflex, spasm of the pylorus. So if you're able to relieve the pain, then the spasm that happens in the pylorus is also aborted. And this helps with the management of the pain in GERD. Now let's look at the mechanism of action of these antacids. So basically, the antacids are neutralizing the acid in the stomach, and it is usually also known to promote angiogenesis in the injured mucosa. Antacids can also bind to the bile acids, and because it increases the pH, it inhibits the release of pepsin. There's also some evidence to suggest that these heavy metals can suppress H. pylori, which is an organism that causes a lot of problems in the stomach. But it should be noted that even though it suppresses it, it does not eradicate. Next slide, please. All right. So in short, we can say that yes, antacids are indicated in the management of GERD, and it is even more effective when an alginate is added to this antacid to potentiate its effects. Thank you very much.
Thank you very much. Talking about alginate-based antacids, Dr. Godas, can you tell us what is really unique about these antacids, the alginate-based antacids?
So Dr. Felix has already told you that antacids are basically alkaline substances. So they neutralize acid, and therefore much of the damage that acid causes, the corrosive injury, if you might like to call it, that is reduced, and it forms a kind of a layer which soothes the hurt mucosa. Now that was good enough, and I think before the PPIs and H2RAs came, the only medicine we had was really antacids. But the problem was one had to take it about 5 to 8 times a day, and the amount that you had to take was pretty high. So if you look at bottle by bottle for people with bad refluxes, it became pretty costly and pretty uncomfortable carrying so much of it. So there was a little bit of research done as to why the acid tends to cause more injury in the esophagus and climb up, and not so much in the other parts, because after all the stomach does produce acid. Duodenal ulcer is becoming less common. So what could be the other mechanism why GERD is such a problem? So people have found out that there is something called an acid pocket. And what the pocket means is that when there is acid and gastric juice and food all together in the stomach, we would imagine that all of them are mixed together and it's a homogeneous kind of a kind. But that doesn't happen. For some reason, it's been found that the acid tends to collect on the upper part near the cardia and the fundus, whereas the gastric contents, probably because they're a bit heavier, there is more food in it, so they tend to come down in the body and then towards the antrum. So if you see this diagram, it means the acid is on the top, waiting to just climb up across the gastroesophageal junction and get into the esophagus and cause problems there, either burning, pain, or mucosal destruction. So this discovery of what is called an acid pocket has been one of the very important discoveries in the last 15 years or so. So can I show the next slide? Yeah. So this is basically a study of how the pH occurs across when you pull the pH probe from down into the uh, the esophagus is on this side and the stomach is on the left side, and you find that when you are pulling it up to the esophagus, just before that area there is a low pH, which means the acid is right there. And if you see in the postprandial state, the picture on the right side, you find the stomach has got most of its food contents, and food usually tends to be somewhat alkaline. It neutralizes acid. Therefore, you see the pH is around 6. But then when you are pulling the probe up, just before it comes into the esophagus, there is a dip, which means there is an acid which is there lying just below the lower esophageal sphincter. And that is called the acid pocket. And then again, when you go up to the esophagus, there is less acid. Okay. So people have therefore tried to target how therapy, an alkaline therapy, would actually come and neutralize the acid in this area where it collects, called the acid pocket. Can I have the next slide, please? So, so this is actually a post-meal MRI scan where you can actually see the acid pocket layer just above the meal layer. It's very beautifully seen, how it floats above the meal, just above, the layer. So that has been a very interesting area. So they wanted to find something which would float up and go and catch up with the acid. So what they discovered was that there is a form of algae. The first ones were, I think, discovered off the sea coast in Norway. And if you make this uh, alginate preparation, alginate is made from algae. It has this property of floating up, just like algae float on the water in the seas. So if you lace it with an alkali, so make it an alkaline alginate, so it goes up and it absorbs water and it becomes a raft. So it becomes a foam or a raft and it floats there. Can I have the next slide, please? So you see, this is a picture which shows that this alginate, how it becomes a foam, it absorbs water, it expands in volume, it stays right on top where the acid pocket is, and therefore it prevents or it makes a kind of a cushion that doesn't allow the acid and gastric contents to go up. In fact, this is what goes up and soothes the lower part of the food pipe. So this is called an alkaline raft or an alginate raft, and this has become very popular. It started off with one brand, which is of course the international brand, which is a OTC product. Now there are several other companies which have been able to make it and make it more widely available all over. So I think that this has been one of the best things that has happened to refluxers, because they can just take in this alginate preparation, and as Dr. Felix rightly mentioned, it works in less than 10 minutes, 5 to 6 minutes. Whereas if you were to take a PPI, it would work the next day because it takes 24 hours to work. So this is what calcium alginate or alkaline alginate preparations are all about. Is
Thank
that
you,
okay?
Dr. Godas. Yes, thank you. But there were some times that we couldn't hear you too clearly, but I hope that during the Q&A, maybe I will double back and then
Sure.
ask you for clarity on certain sections.
Sure.
So, so Dr. Felix, what would you say an ideal alginate-based antacid should be, if you can expand a bit more on what an alginate-based antacid?
All right, thank you very much. So as Prof said earlier on, the addition of alginate to the antacid preparation has obvious advantages. Now, this was necessary because just the antacid alone could not help much. So just to reiterate, we have inhibition of the gastric acid, and then when you add the alginate, you're able to solve the acid pocket problem that Prof has explained, to a very large extent. Next slide, please. So this is supposed to be a schematic representation of everything we've been talking about. So you can see the raft that has formed on top of the acid pocket, and this prevents the acid from escaping. So for the ideal antacid alginate combination, the raft should be able to form properly, and it should have the ability to really neutralize the acid in the stomach. This is known as the acid neutralizing capacity of the antacid, and it is expressed usually in milli equivalent, and usually you're looking at a pH of around 3.5 to 4. Its ability to increase the pH of the stomach. And I'm sure we all know when we are increasing the pH of the stomach, it means we are decreasing the acidity. It should also have, the raft being formed quite early. Next slide, please. So it should be water soluble, it should have fine particles, and it should not be easily absorbed, because you want to decrease the acidity in the stomach, but you don't want to alkalinize the blood. It should not cause any constipation, or it shouldn't act as a laxative. In fact, that is why aluminum and magnesium is usually combined, because magnesium would usually cause diarrhea, and aluminum can cause constipation. So if you add the two, then it cancels out. And as I said earlier on, it shouldn't cause any systemic alkalosis. It should have long-term impact. Generally, antacids will not have a very long duration of action. So if you have an antacid preparation that can act for a very long time, that is a plus. It should be able to inhibit pepsin, and it should be non-toxic with no major side effect. It should be easily available, and in these days, most importantly, it should be cost effective. Next slide, please. So talking about an ideal alginate antacid combination, I happen to have reviewed this paper which compared a particular antacid to a number of antacids that were available in the market. Now, some, lab situations were mimicked to the extent that the individual antacids have to be compared as far as its ANC is concerned and how fast or otherwise the raft is formed. Next slide, please. So we had 1, 2, 3, and 4 different preparations with their compositions, and then this was compared with AFO, which was the antacid in question that was compared to those already on the market. So if you look at this diagram, you realize that for sample, let's call the first sample AFO. For sample AFO, it took about 25 seconds for the raft to form. And then if you compare that with AF/1, it took as long as 60 seconds to have the raft forming. What it means is that the first sample would be a better alginate combination compared with the second sample. For AF2 and AF3, realize that it didn't form at all. And for AF4, it formed just at time 15 seconds. So you realize that the shorter it takes for the raft to form, the better the antacid preparation. Next slide, please. Now let's suppose to look at the acid neutralization effect. Again, if you look at AFO at time 0, less than a minute, already the pH of the stomach had been increased from the usual 2 to 3 to as much as 7. And this happened very early, less than a minute, which means that if you have a patient having symptoms, just by taking this particular antacid in less than a minute, you're having the pH increase to as high as 7.09, which is quite a good figure. Can we move to the next slide? Now, this is just a graph representation of the acid neutralization. Again, if you look at AFO, realize that it's able to maintain a pH of as high as 8.25 milliequivalent. That is the acid neutralization capacity. But AF2 also did that to as high as 11.44. Last slide. So in summary, an ideal antacid alginate combination should be one that is able to neutralize the acid in the stomach very, very quickly, able to sustain this increase in pH for a considerable period of time, and also able to give you a thick raft formation that is happening very early and preventing acid from escaping from the stomach into the esophagus. Thank you very much.
Thank you very much, Dr. Felix, and also thank you to everybody who has been tuned in since we started. The explanation that Dr. Felix gave also was the end of our panel discussion, but it's not the end of the CPD. So it's time to hear from you. I'm sure you all agree it's been a very stimulating discussion, and we've learned some new things, especially the acid pockets, the raft formation, and some other aspects as well. So it's now time for your questions. And Dr. Raul, if you can help us with whichever questions that have come through. Thank you.
Thank you so much, Dr. Priscilla, for this wonderful coordination and for nicely moderating this program. Thanks to Dr. Godas and Dr. Felix for uh, sharing your rich experience by responding to each and every point which is discussed. And you rightly mentioned, Dr. Priscilla, that it was quite exciting. I personally enjoyed the entire discussion, quite from the basics. I mean, starting from the definition, moving slowly towards causes, risk factors, diagnostic tools. They can be used like GERD-Q, for example. They can be used very easily in primary care setup. And thanks to Dr. Chaudhary, who has wonderfully explained non-pharmacological management, and then moving on to the pharmacological side. And thanks to Dr. Felix for sharing this study findings. So let us move on to the questions. Please allow me to take questions on behalf of our audience, and I will keep on mixing the questions coming from the physical gathering, which is there in Ghana, as well as I will take up some questions coming from the online audience. So there is a question from the team sitting there in Accra, that is there any ongoing study or recent study on the prevalence of GERD at the primary care level in Ghana or in sub-Saharan Africa? So, Dr. Priscilla and Dr. Felix, I think would you like to respond to this question?
Okay, yes. So thank you very much for the question. I didn't come across any systematic review protocol that had been published to suggest that something like that was in the offing. And so I think it shows that it's an area of research that we can consider, especially also the fact that we have a tool, which is the GERD-Q, which can sort of be used in primary care to help us address that. There were a few studies that talked about the evaluation of upper GI endoscopy findings. And so, as we have already found out, that is one way to diagnose GERD, but we also have other non-diagnostic ways of diagnostic GERD. So, as far as I saw, I didn't find any ongoing studies in Ghana, but I'll leave that to Dr. Felix to also comment. Thank you.
Yeah, so as Dr. Van Dyke, has told all of us, there's not one I have also come across. And This has been because, diagnosing GERD has always been thought to be a function of some particular diagnostic tools, i.e., the pH, monitors, the manometry. But with this new information we have that we can use the Get Cure questionnaire, I think it's just about time we have some data on this particular condition, because yes, I must say it's very common in our part of the world. Thank you.
Thank you. Dr. Chaudhary, would you like to contribute before I move on to the next question?
No, I think I wouldn't be knowing about sub-Saharan Africa, but I just wanted Dr. Priscilla mentioned that, and I would reinstate that it depends on whether you want to do it as a questionnaire survey or you want to do it as a investigation-based survey. So endoscopy is common, but endoscopy has its fallacy because about 40% of patients with reflux don't show changes, and they are called as endoscopy normal reflux disease. So the test which is most reliable is actually a 24-hour pH metry. But to do it in a field setup is a absolute impossibility, practical impossibility. I mean, the expense and the logistics doesn't make sense. So we all resort to questionnaire-based survey. And I'll just, for the audience, I'll tell you how geographical areas, ethnic groups, languages, and cultures matter. So, the GERD survey that was done in China, I think it was the second Rome study. That time they found that the reflux disease disorder rate in China was very low. And then when they tried to analyze what happened, they found that in the Mandarin language, they don't have an appropriate word for heartburn. So when you translate, it wasn't really conveying the meaning. So people were not able to express themselves. So when you take a questionnaire to the field, you have to field test it and actually see that people are able to relate to your questions. So it's very dependent on cultures and languages. But I think Dr. Felix answered it very well. It's a lot of scope for people to work on in Ghana, and my colleagues there can do a great job.
Thank you. It's very valuable insight, Dr. Chaudhary. Thanks for sharing that. Let me move on to next question. That is, what are the other causes of GERD apart from hyperacidity?
To whom?
I mean, it's open to all panel members.
Okay, okay,
So,
okay. I'll take that. I'll take that. So I'll be on the batting line for the ones, and then
Sorry,
Dr.
Dr.
Felix.
Rahul, we didn't hear the question too clearly.
Okay,
yeah,
so
doc,
apart from acid, are there any other causes of reflux disease? So there are two types of reflux. One is basically acid reflux, which is the common one, and there is one where actually it is a volume reflux. So there are two types broadly. It's called acid refluxes or volume refluxes. Volume refluxes don't have so much of heartburn, but because there is a large volume that comes up, so they often get water brash. They can get choking because it's actually a lot of gastric fluid coming up to the mouth, but not necessarily very rich in acid. And there is a third type, which has now become a little less, shall we say, popular. Earlier on, it used to be very common. It was called biliary or bile reflux. So there was a bile reflux also, which would come up all the way up to the esophagus. And in our young days, we used to do studies of taking mucosal tissues to see for bile salts, to diagnose bile reflux in the esophagus. But those are actually, they have kind of fallen by the way. It's not so common. At the moment, it's only volume refluxes and acid reflux. To cut it short, these are the two.
right.
And third, if
Yeah.
you want from MCQ point of view, MCQ question, it would be bile reflux. Yeah, yeah, it's very important.
Yeah. Dr. Felix, Dr. Priscilla, would you like to reply to this question?
Well, we didn't quite get the question clear from our end.
Yeah.
If you could repeat it.
Which are other causes of GERD apart from hyperacidity?
Well, so I think Prof has answered it, quite well. But once you have anything that is increasing the pressure in the stomach, So sometimes it is not just a matter of the volume being too much, the same volume, but because the pressure in the stomach has reduced from whatever cause, the volume in the stomach now tries to exit, out through the esophagus. So I think basically that is what Prof has, very nicely elucidated. Thank you.
Perfect. So I will move on to next point, which is about the alarm symptoms. And thanks to Dr. Felix for letting us know about the alarm symptoms. Certainly, it will guide to our audience, right? And they will decide when to refer to the specialist. So one of the symptoms that you mentioned was jaundice. So is there any association between jaundice and GERD?
Well, not a direct association, but sometimes you can have a malignancy that is moving to the liver. And, some of the malignancies can be very silent for a very long time. And the only subtle thing that you might just get is the fact that this malignancy has moved to the liver, and that will be, clinically detected as jaundice. Otherwise, there's no direct link between GERD and jaundice. Only that if you're having a malignancy that is mimicking GERD, jaundice can be one of the things that would help you to pick this malignancy up. That is if it moves to the liver or it blocks the flow of bile. Thank you.
Right. Okay. Now, there are many questions about the association between GERD and H. pylori. So that makes my next question that is there any association, first of all, between GERD and H. pylori, and how is that link matters for our audience?
Whom are you asking?
It is again, sir, open to all panel members.
Prof can take that one.
Okay, so I'll take the question first from the Indian perspective. There is something common, I guess, between India and between Ghana. We are both developing countries. Okay, so our Helicobacter pylori prevalence rates are very different from the Caucasian Western developed countries. So in the developed countries, H. pylori prevalence rates are usually less than 5%. In our country, it's about 40% of everybody undergoing endoscopy. When we do a rapid urease test, about 40% are positive. I think that, probably in your country also the rates would be high if you did that. Now, the problem is when you diagnose Helicobacter pylori during endoscopy, the patient is worried and he obviously wants treatment for Helicobacter. And we all know that presence of Helicobacter in the stomach causes dyspeptic symptoms, gastritis, may in an indirect way also increase acid production, but in an indirect way. But overall, H. pylori, by causing gastritis, actually has been found to reduce the acid production in terms of milliequivalents. So there is a lot of debate that if a person has got primarily reflux disease with a lot of acid being produced and he has got H. pylori, H. pylori may be playing a protective role by reducing the acid production. So there is a lot of debate in our Indian society whether to treat the H. pylori if you find it or to let it be. On the let it be side, there is a counter argument that people in the West have put it as a precancerous condition. They have put it as a class 1 carcinogen. So they would say that how can you let it be in the stomach and let people be predisposed to gastric cancer? Uh, Probably that doesn't apply to our country because if H. pylori was such a precancerous condition, then we would have been having an epidemic of gastric cancer, which we don't have. So at this point, there is a little bit of divided opinion on that. But in general, Helicobacter pylori gastritis causes reduction in acid, and sometimes treating it can cause rebound hyperacidity in patients with reflux. That's my view. I would like to learn from Dr. Priscilla and Dr. Felix.
Want to add some? Yeah.
There were some studies, like you mentioned, the Caucasian studies, where they would rather recommend, and it has to do with the fact that they saw positive outcomes with the treatment of H. pylori. But having said that, as you rightly alluded to, the prevalence of H. pylori in the Caucasian population is relatively lower than our population. And so again, it throws us the question that we probably need to look at conducting our own studies to see whether the management of GERD in our environment for those that are H. pylori positive as well makes a difference or not. Those are my comments.
Yeah, so the little I would also want to add is that, in fact, in Ghana, the prevalence is, anything between um, 50 and 65%. In fact, for some areas, it's gone as high as to about 70%. That's the prevalence of H. pylori. So it is really, really common here. And as Prof said, we don't have, that degree of gastric cancers walking about. So to the extent that when you take out H. pylori, the acidity can increase. There is so much confusion as to whether to eradicate H. pylori when you are treating GERD. However, when you have patients with any form of organic dyspepsia or any form of, let's say, peptic ulcer disease, in addition to GERD, then you want to eradicate H. pylori, because for such a patient, we know that if you eradicate H. pylori, you would at least help, promote the healing of the gastric pathology. And of course, at that time, you're not sure what happens to the esophageal pathology. But whatever it is, for such a patient, I think eradicating H. pylori would benefit more than just leaving it there. Thank you.
Thank you so much. Our next question is about pyloric stenosis. For someone who has had pyloromyotomy for pyloric stenosis, will there be increased risk of developing GERD?
So if the surgery has been done well, it should actually reduce the chances of GERD, because the pyloric stenosis was causing gastroparesis. That was, the stomach was not able to empty well, and there must have been some degree of reflux symptoms if it was there. Now, if you have made the outlet a little easy, for the food to go down, then actually GERD symptoms should really come down. So I think that's been good, that although you have treated the pylorus, you might actually have benefited the GERD.
Right. So,
Would
Dr.
you agree, Dr. Felix?
No, I have nothing to add, please.
Fine. So, our next question is again from Team Ghana, that for an individual who has persistent GERD without treatment, so averagely, how long does it take to develop metaplasia and dysplasia of the squamous cell of the mucosa?
Very good question. So let me tell you. So there are people, of the 30% of the people that Dr. Priscilla talked about, most of them are going to live normal lives with normal life expectancy and die at the age of whatever is your life expectancy from many other causes, but not really due to GERD or malignancy. Having said that, Barrett's metaplasia, which is often an outcome of long term severe reflux disease with erosions, that usually occurs in our population in India in about 2 to 3% only. I'm not talking about gastric erosions. Gastric erosions, that is Los Angeles type A, B, C, they are common. But Barrett's metaplasia usually occurs in only 2 to 3%. And of the Barrett's metaplasia, only a small proportion will ever develop carcinoma. So most of them are not going to die of carcinoma. They shouldn't be so worried. But epidemiologically, if you look at it, yes, there has been an increase in reflux disease over the last 20 years. And along with the increase in reflux disease, statistically, there has also been an increase in lower esophageal adenocarcinoma, lower end esophageal adenocarcinoma. This has been well observed in the Western world. And I guess that, that is something which we have to reckon. But that is in terms of epidemiology, not in individual cases. So I don't think that people should, just because they have heartburn, start thinking that they're going to have esophageal cancer and die.
Right. So can I move on to next question?
Anything to
Uh,
add, Dr. Priscilla or Dr. Felix? No?
No, please. I think you've handled it quite well.
Perfect. So uh, is there any way GERD connected to hemorrhoids? Because one of our audience mentioned that he or she is seeing many patients with hyperacidity complaining of hemorrhoids.
I don't think there's a direct connection, but usually there is a, a pattern of lifestyle and habits and shall we say constitution. So people who have GERD are usually somewhat overweight. They might have irritable bowel syndrome or some amount of bowel disturbances where they apply a lot of pressure, to clear their bowels. And straining at stool and increase in intra abdominal pressure can actually worsen both. It can worsen reflux and it can also lead to the development of hemorrhoids. Having said that, hemorrhoids are so common in our country. I think in adults we would see hemorrhoids in about 30 to 40%, most of them asymptomatic, but it does happen. But it usually occurs in people who have been through, either ladies who have been through multiple pregnancies, or in gents who have had a long period of so-called constipation, which is often a part of a irritable bowel syndrome or IBS-D variety, IBS-C variety, which leads to the development of that. So I don't think there's a direct correlation, but it's an indirect correlation.
Right. Okay. So since there are many questions, right, and it is very difficult to take all of them, uh, and we are now, I think, running short of time. I would like to move on and take one more question, and that last question is about the stomach acid. We all know that gastric acid plays a role in the chemical digestion, and I think Dr. Felix has briefly touched that point. So, when acid has its role to play in digestion, and when antacids are given, won't antacid lead to the improper digestion?
So antacids actually do not increase the pH of the stomach very much. It neutralizes the acid only partly, not fully. Because to fully neutralize the acid, you would actually have to drink 2 bottles of antacid every 2 hours, which is not practical. The greater suppression of acid comes with the use of proton pump inhibitors. And proton pump inhibitors can really increase the pH to high levels, which is, they almost flatten the acid production curve. That is a problem, because I'll tell you, initially people thought that if you completely stop or block the acid, it's good for you. Symptom relief is good. Okay. But having said that, why did nature create hydrochloric acid in the stomach? It must have been with a purpose. So it had two purposes. One was for digestion, and the other part was it acted as a bacteriological or a barrier to infections entering the gut from the upper end. So people who have been on long-term PPIs, they do have a lot of complications. Now the list is long, the frequency is small, but Dr. Felix alluded to it. So it's been found that people who have been on PPIs for more than 2 to 4 years, there's a slightly higher risk of GI infections, gastroenteritis. The suppressed acid causes impairment of absorption of iron, B12, vitamin D. Okay, so all those have been well known. So the question is that don't suppress acid too much and for too long. Do it for short periods or do it moderately so that your symptoms are relieved and you are able to get along well with life. So from that point of view, I think the antacid alginates are pretty good, and I think that they let the pH and the acid keep bouncing up and down. So it's not really a complete hypochlorhydria or achlorhydria that we are producing. And I think that that generally would be a better, more healthy option. The only thing, if I might add, is that this alginate comes as sodium alginate. So whenever there is a sodium attached, uh, you have to understand that it works quite well. And the small dose of sodium, after all, we put in the baking soda for baking cakes also. But overdose of sodium has been reported that once in a while, if a person has got hypertension, it can push up the BP a little. So one just needs to be cautious with that.
Right.
But it's a
Dr. Pres,
wonderful
yeah.
product. I must tell you, I have used it and I really love it.
Thank you so much, sir. Dr. Priscilla, Dr. Felix, would like to contribute to this question?
So I think just as Prof has said, the PPIs have quite a number of side effects. Apart from all that Prof has said, it actually has some renal side effects, and sometimes even it has effect on the bone. It causes some bone problems. So using PPIs to block the acid completely is not as such a fantastic thing to do as you would think from just the theory. And looking at it from that point of view, then the alginate-based antacids should be looked at in certain instances. Thank you.
Yeah. So I just want to add that usually we need to be patient-centered in our approach to management. So if, for instance, you realize that a particular patient will benefit from the antacids, then it will be better you consider that first for a period of time because it's also cost effective before you then go ahead and consider the PPIs. And some patients will benefit first of all from the PPI. So you just look at the patients that you have sitting in front of you using the symptoms, and then you make a decision whether they'll benefit from an alginate-based antacid initially before they then go on to choose a PPI for them. Thank you.
Thank you so much. Thanks once again to all respected panel members. I have really enjoyed this interaction. I wish we could continue and take up all the questions, but unfortunately we cannot cover all of them. So, dear audience, as a we are observing this week as a GERD week, and that is why we schedule this program today. And as a part of this initiative, we are going to circulate our online newsletter called Synapse, and you can expect that in your inbox by Friday night. So, Synapse, this edition is dedicated for GERD. So, where you will get to see the recent updates of GERD, what is happening in this area globally, as well as some important articles, case study, and KOL opinion. So thanks once again to panel members as well as the audience. I would also like to pass on our sincere thanks to our professional bodies who has accredited this program with CMA and CPD points. Now, I would like to request our healthcare professionals from Ghana to stay back because we will continue this session for this particular group, and the audience outside Ghana can leave the program. Thank you so much, and thanks to Dr. Chaudhary. Thanks once again.
Thank you so much. It was a pleasure meeting you, Dr. Rahul, Dr. Priscilla, and Dr. Felix. Enjoyed the discussion.